Vanakkam. Perhaps one of the most important concepts that not only plastic surgeons, all surgeons need to know is the process of wound healing. All surgeons need to understand and remember how a wound heals. And this wound healing occurs whether we suture the wound or leave it open. And this process of wound healing begins the moment the wound is created. This video deals with this amazing process of wound healing, and I have dealt with it in detail enough to understand it and simple enough to remember it. Acute wound healing is a process that occurs when a wound happens, whether you suture it like this or it is left open to heal by secondary intention like this. In both scenarios, the process by which the healing occurs inside is the same. This process of acute wound healing occurs in 4 steps: the stage of hemostasis, the stage of inflammation, the stage of proliferation, and the stage of remodeling. To understand more about these steps, we shall see them in detail. First, the stage of hemostasis. When a wound occurs, obviously there has been injury to the blood vessels. So there is a vascular injury. This stage of hemostasis is the immediate physiological response to vascular injury, and it starts immediately at the time of injury and lasts for about 15 hours. The primary objective of this stage is to stop hemorrhage and create a provisional matrix for subsequent healing phases. The main players in this stage are the platelets. This stage of hemostasis actually consists of 4 main sub-steps: vascular constriction, platelet aggregation, coagulation cascade, and clot stabilization. First, the vessels that have been injured have to constrict to reduce the amount of blood loss. This step of vascular constriction is carried out by the smooth muscles in the vessel walls, which contract. This step is mediated by local neural reflexes and certain substances, of which endothelin and thromboxane A2 play an important role. As a result of this vascular constriction, there is narrowing of the vessel and thus reduced blood loss. Next, a platelet plug forms. When injury occurs, the platelets are exposed to structures like the subendothelial collagen, and this exposure initiates the platelet plug formation. It is mediated by receptors and ligands like the von Willebrand factor. This causes activation of the platelets, which release storage granules and adenosine diphosphate, serotonin, and calcium into the wound. This further recruits more platelets to come and join to form the primary platelet plug. But it is very soft and it needs much more strengthening in the form of the coagulation cascade. The coagulation cascade can occur via an extrinsic pathway and an intrinsic pathway, then follow a common pathway. The extrinsic pathway is triggered by the tissue factor released from the damaged extravascular cells. The intrinsic pathway is triggered by the exposure of blood to negatively charged surfaces like collagen. Then the common pathway occurs, which is the final stage of the coagulation cascade, where the intrinsic and extrinsic pathways converge, leading to blood clot formation. This pathway begins with the activation of factor 10A, which combines with factor 5 to become activated factor 5, that is 5A, and this, along with calcium and platelet phospholipids, forms what is known as the prothrombinase complex. This complex converts prothrombin, which is factor 2, into thrombin, which is activated factor 2. This thrombin acts on fibrinogen and converts soluble fibrinogen, factor 1, into insoluble fibrin, which consists of small bits of fibrinogen. So now, when fibrin is formed, it is no longer floating freely in the blood, it becomes sticky. These sticky fibrin molecules stick to each other, they form long strands and create a net or mesh, and platelets, RBCs, are trapped in this mesh. This covers the injury to the blood vessel and forms a clot which is soft and weak. This clot has to get stabilized. Another clotting protein called factor 13 acts like a cement which cross-links the fibrin strands together. Now the mesh becomes tight, firm and stable, and this is the stable blood clot. So now with this stage of hemostasis, the emergency has now come under control, bleeding has stopped completely and losses have been cut. Now the stage is set for the body to react. That brings us to the stage of inflammation. The stage of inflammation where the body starts reacting to the injury. It typically occurs from 0 to 3 days post-injury, and the primary objectives of this stage are to achieve biological debridement and to release chemical signals to initiate the repair process. The main players in this stage are the neutrophils and macrophages. The stage of inflammation starts with a vascular response, followed by neutrophil infiltration in the early stage and macrophage transition in the late stage. In the stage of hemostasis, we saw vascular constriction. In this stage, vascular dilatation begins. Along with that, there is an increase in the capillary permeability, as a result of which plasma, proteins and white blood cells leak into the interstitial space. Thus sets in the clinical signs of inflammation. Next, neutrophil infiltration begins by 24 hours. The neutrophils move from the bloodstream to the tissues. The steps by which this neutrophil infiltration occurs can be described first as margination, where the neutrophils leave the center of the bloodstream and go towards the wall of the lumen. Then they roll along the endothelial lining. They get adherent at some point. Then they start crawling along the endothelial layer and find small gaps through which they enter the tissues by a process called diapedesis. These neutrophils have two important functions. The primary role is phagocytosis, that is, engulfing the bacteria and the foreign debris, and secondarily, they release reactive oxygen species and proteases to kill the microbes. Once their task is complete, neutrophils undergo apoptosis and are cleared by the macrophages who are going to come in next. Along with macrophages that come into the tissues, some neutrophils also get converted to macrophages, specifically the M1 macrophage. This occurs by 2 to 3 days after the injury. These macrophages are the master regulators of wound healing, and the M1 type of macrophage mainly concentrates on debridement of the remaining bacteria and spent neutrophils, and then it undergoes the transition from M1 to M2 type of macrophage. This M2 macrophage secretes essential growth factors and cytokines like the transforming growth factor beta, which stimulates the fibroblasts, the vascular endothelial growth factor which initiates angiogenesis, and the platelet derived growth factor which recruits cells for the proliferative phase. This stage of inflammation creates a clean environment, which is a prerequisite for the successful deposition of new collagen in the next phase. So the inflammatory phase acts as a bridge that cleans the construction site of the wound and prepares it for the reconstruction or the proliferative phase. The stage of proliferation is otherwise known as the phase of reconstruction. It typically starts from 3 days and extends up to 3 weeks post-injury. The aim of this phase is to fill the wound defect and restore the skin's protective barrier. The primary players in this stage are the fibroblasts. This stage consists of 4 steps: matrix synthesis, angiogenesis, epithelialization, and wound contraction. Matrix synthesis begins when fibroblasts migrate into the wound site. They proliferate and begin synthesizing the extracellular matrix. They also produce type 3 collagen, glycosaminoglycans, and fibronectin. Then New blood vessels must form to bring oxygenated blood to the growing tissues. This happens by the process of angiogenesis or neovascularization. This step is actually stimulated by the vascular endothelial growth factor and low oxygen tension or hypoxia, and the endothelial cells from the intact vessels at the wound edge proliferate and start sprouting into the wound. So when the vascular endothelial growth factor stimulates endothelial lining of the intact vessels, sprouting occurs headed by the tip cells. These tip cells are followed by the stalk cells, and as they get in touch with each other, anastomosis between the two sprouting vessels occurs and perfusion increases. Ultimately, there is a dense network of capillaries giving the wound its characteristic red granular appearance known as granulation tissue. But the wound is still not covered with epithelium. This can occur only by the process of epithelialization to restore the epidermis. The main players here are the keratinocytes, which occur at the wound edges, and also from the residual dermal appendages like the hair follicles. The way in which these keratinocytes cover the wound can be by the leapfrogging model, where the suprabasal cells migrate by rolling over the leading basal cells, or the tractor tread model, where the superficial layers passively displace over the basal layers, or the Ussi and Safferling model, where the basal and suprabasal keratinocytes migrate collectively and continuously in a concentric pattern around the wound. Whatever the technique, when the keratinocytes from opposing sides meet, they stop migrating and thicken to restore the epithelial layers. Sometimes the wound may be too large to get epithelialized fully. So to reduce the size of the wound, there is a process called wound contraction that occurs. In this example, you can see that the wound is too large for the epithelialization to cover it fully. So the wound contracts like this, and the epithelialization then is possible for complete healing. We have already seen the action of the fibroblasts. A specialized subset of fibroblasts called the myofibroblasts appears around day 5 to 7. These cells contain alpha smooth muscle actin, allowing them to contract much like muscle cells. They grip the wound edges and pull them inward, significantly reducing the surface area of the wound. The rate of contraction is approximately 0.6 millimeters to 0.75 millimeters per day. By the end of the proliferation phase, the wound is closed and filled with a collagen-rich tissue, but it does not have the organization or strength of normal skin. This strength is addressed in the final remodeling phase, or the maturation phase as it is sometimes known, which is the final and longest stage of wound healing. It begins at approximately 3 weeks and can persist for even a year or more. The aim of this stage is to achieve maximum tensile strength and functional integrity of the new tissue. The main player here is collagen. So in this stage, there will be collagen remodeling, realignment and cross-linking, regression of vasculature, and recovery of tensile strength. Collagen remodeling actually concentrates on the type 3 to type 1 shift. During the proliferative phase, the wound is filled with type 3 collagen, which is thin and disorganized. In the remodeling phase, fibroblasts secrete matrix metalloproteinases (MMPs) that break down the type 3 collagen. Of these, the collagenases, that is MMP 1, 8 and 13, cleave the type 3 collagen into smaller fragments, which are further degraded into smaller peptides by gelatinases, which are MMP 2 and 9. Apart from the shift of type 3 to type 1, new thicker fibers of type 1 collagen are also synthesized. This continuous cycle of synthesis and degradation is known as collagen turnover. Type 3 collagen is a homodimer of 3 alpha 1 chains, while type 1 is a heterotrimer of 2 alpha 1 and 1 alpha 2 chains. But these type 1 collagen fibers that have been synthesized and formed have to be realigned because the collagen fibers are initially deposited in a random basket weave orientation, and over time these fibers are reorganized and aligned along the lines of mechanical tension acting on the wound. Along with this realignment comes intermolecular cross-linking between the collagen strands, significantly enhancing the structural stability of the scar. While the wound gains strength rapidly during this phase, it never actually reaches the strength of the original uninjured skin. The progression of tensile strength follows a general timeline where 3% of the original strength is gained by 1 week, 20% of the original strength is gained by 3 weeks, and by about 3 months to 1 year, there is a plateau in the increase of tensile strength at approximately 70 to 80% of the original strength. For all the stages of healing that we have seen, there was a need for an increased blood supply because there was a large metabolic demand of the tissues. But now, the dense capillary network formed during angiogenesis is no longer needed. The unnecessary blood vessels undergo apoptosis. This is when the regression of the vasculature causes the scar to change from a fleshy, beefy red or pink to a pale, silvery or skin-toned color. The tissue also becomes less cellular and more fibrous. The remodeling phase transforms a fragile bridge of granulation tissue into a stable, functional scar. Summarizing the entire process of acute wound healing, in the first stage of hemostasis, where the aim is to prevent excessive blood loss, initial vasoconstriction occurs, the platelets then adhere and form a platelet plug, the coagulation cascade is triggered, and conversion of fibrinogen to fibrin occurs, which stabilizes the platelet plug into a thrombus. In the next phase, that is the inflammatory phase, the aim is to neutralize the pathogens and clear the cellular debris, and here vasodilatation occurs to allow leukocytes to enter the wound. These neutrophils arrive in 24 hours to perform phagocytosis, and macrophages arrive later to continue phagocytosis and release cytokines and growth factors to start the next phase, that is the proliferative phase. The proliferative phase, which lasts from 3 to 21 days, concentrates on tissue reconstruction, in which fibroblasts synthesize extracellular matrix and type 3 collagen. Angiogenesis also occurs to bring more blood supply, epithelialization occurs to close the surface, and myofibroblasts facilitate wound contraction. The final remodeling phase, which occurs from 3 weeks to 1 year or more, is characterized by type 3 collagen being replaced by the stronger type 1 collagen, and the collagen fibers are also reorganized and cross-linked, and the scar becomes stringier and less vascular. In other words, it matures. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about what is to come in this series on essentials in plastic and reconstructive surgery. And do not forget to subscribe to stay connected with the latest in learning plastic surgery, hand surgery, trauma surgery, and ethics.